This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 593, recorded on March 20th, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Continuing our analysis of COVID-19 and SARS-CoV-2. Joining me here right in studio, Daniel Griffin.
Hello, everybody.
And also in studio, Ori Lieberman.
Hi, everybody.
Welcome back. We have here two MD PhDs.
I haven't gotten the MD yet. So.
That's right. You haven't got an MD yet. You're in the program.
Yes.
And Daniel's immensely experienced MD PhD, who maybe you can aspire to one day.
Yes, absolutely.
Isn't that cool? So that's good. Welcome, both of you, and Daniel especially, because you're, as we will hear, taking care of many patients. And everyone else is here to join us from Western Massachusetts. Alan Dove.
Good to be here. It's overcast and 57 Fahrenheit, and good day to be indoors.
For many reasons. From Austin, Texas, Rich Condit.
Hi, everybody. 58 degrees, 14 C, light rain will continue through tomorrow. Great lockdown weather.
From southeastern Michigan, Kathy Spindler.
Hi, everybody. It's 49 Fahrenheit, which is 8 Celsius, and it's going to drop down to 20 Fahrenheit overnight.
From Madison, New Jersey, Brianne Barker.
Hi, everyone. It's great to be here. It's 60 degrees Fahrenheit and kind of gray outside.
It is gray here. And finally, last but not least, from Fort Lee, New Jersey, Dixon Despommier.
Hello there, everybody.
Everyone sounds good.
Is everybody healthy?
No.
I am.
So far.
Yep.
Nope, but there's a recent report out from China that said the first 209 cases that they had in one province, 90 of those cases had diarrhea as a first symptom. Mm-hmm. They didn't do as well as the others did.
What do you think about that, Daniel?
It's interesting, but I'm seeing that a fair amount of cases have diarrhea, and actually one of the recent cases that is currently doing poorly and intubated, the presentation was just diarrhea, nothing else, no fever, no respiratory. Wow. And I'm also finding that if you start really asking people, because I'm kind of those thorough historian type, the old fashioned, it's like, I know you have a fever and you have trouble breathing, but I actually care about other things. So how's your back? And a lot of people are saying, actually, you know what? No one really asked, but yeah, my back's really bothering me. And so what about the diarrhea? Well, it's not like diarrhea, but yeah, I'm having loose stools. So I think the more you ask the questions, you realize that you really can't, when you look at a big publicized, research thing, they're checking boxes. But if you really start seeing enough patients, and unfortunately I'm seeing enough patients, you start realizing that gastrointestinal symptoms are significant, are common. They're not uncommon like it looked like in the early reports, at least in the cases I'm seeing, which the N is growing by the hour at this point. And you're seeing muscle and other manifestations. So the typical fever or not, respiratory symptoms or not, as I tell people, it's a viral syndrome. It presents like a viral syndrome. If you ever had a viral syndrome, yeah. If you ever had a really bad viral syndrome, exactly. Hopefully most people have not had as severe a viral syndrome as this can become.
So the individual with only diarrhea, no respiratory symptoms, why would they have been admitted for the diarrhea?
So they get admitted for the diarrhea, and this is an interesting issue that I was recently an hour or two, discussing with Yossi Sabo, who's in with David Ho and Stephen Goff, and there may be an immune issue about who does poorly, who does well, based upon route of acquisition. So if this actually, let's say you got a fecal oral, but this is theoretical. So, but it's interesting to look at the observations, and then hopefully we can do the science to sort it out. But let's say you get it in your eyeball. That's not a great place for replication. Maybe that gives your immune system enough time. But if you get it in your intestinal tract, which is really a huge surface area, is that an area where the virus can act in a certain way, where, you end up with worse outcomes? We're still, and I think this is really critical for us, because we're trying to figure out who are those patients that do really poorly versus those patients who 80% are going to be able to stay at home. And
so the patient with diarrhea, you wouldn't normally be checking for SARS-CoV-2, would you?
So you wouldn't. And I think the paradigm switch that I've been pushing now for a couple of weeks is just this. And actually, it was an ICU doc. We were talking, Lisa Santarello, and I say a brilliant ICU doc. And we talked for a little while. And she goes, so let me get this straight. It's a virus and it presents like a viral illness. I said, exactly. Oh my gosh. And so unfortunately that woman came in and was seen by another infectious disease doc, again, really a bright guy, actually someone I work with. And he's like, I just, from everything I've been told, it didn't pop up on the radar. I mean, there was no fever, there was no respiratory symptoms, there was no known contact. It was, it was no white count, no fever. She just had loose stools and felt crummy.
The patients then went on to exhibit those other symptoms, I think, didn't they?
So you're correct. So this woman, as a just sort of to use a personal thing, is that she then went on. She ended up having such severe respiratory distress, such severe trouble breathing. She's now currently intubated. So yes, later on, the people that do poorly, but some people, as we now know, they actually never really feel so bad, and those are the ones that scare us because they're out there, they're going to their job, they're
having loose stools everywhere.
Yes.
So give us an overview of the situation. You're seeing a lot of patients, right? More than most people?
Quite a bit. And part of it is that I have several roles, right? So I'm here at Columbia University and I've been in touch back and forth. Actually was just meeting with a couple of the infectious disease doctors. And one I've kept close touch with through the last few weeks is Justin Aaron, who actually was on TWiV, right? Was on TWiV, yeah. And it's nice. I was his teaching attending, his clinic attending for a number of years when he was going through his fellowship, and I was precepting, supervising him, and he is now in the trenches on what is the newly formed Columbia COVID service, and I was also speaking to Thomas, another one of the ID docs, and my other hat, and this is where I'm seeing the largest number, is as the chief of infectious disease at Pro Healthcare Associates. And this is the group that identified the first case in Westchester. And actually, of all the positives you see in the New York area, at least as of yesterday when I got the numbers, a quarter of those positives were identified by our organization.
That's amazing.
And so I basically get updates on all those people. And we're constantly educating clinicians so that they know how to manage the patients in the outpatient setting as much as possible. In addition to my hospital work, where I've seen a number in the hospital intensive care unit versus the floor, I also go out to all the urgent cares and I make sure that the process is smooth for diagnosis and testing. I was actually at a drive-through site yesterday in Syosset, which saw 250 tests in a day. That's just the drive-through. Forget about what's going on in the urgent care. Because of this, I've seen a lot of cases actually since February, which we were able to confirm once the testing was available. But we procured those samples early on. We said, you know what? I have enough of a clinical suspicion. I'm going to, at this point, recommend you stay home, quarantined. Sort of this, what I've termed as social cohorting, which is if you're home and it's your wife and it's your son and maybe your mother and whatever that group is, you stay together. We're basically applying cohorting that we do in the hospital. We're now working with the Department of Health and we're cohorting them in the outpatient setting to prevent these focuses of spread. And it's been interesting. I've been able to track people that have done quite well. And I'll say 80% of the time, but I mean by quite well is not severe enough to go to the hospital. And then I've also seen the other end where people severe enough that they require intubation. And then maybe, there's a lot of darkness here, but let's say something on the bright side. I've actually seen patients get better, the outpatients that never required hospitalization. I've seen them actually have symptoms resolve. And we've discharged several patients from the hospital, even patients that required intensive care unit level support. So
what fraction?
It's tough. I think that if you look at the numbers, and I'm hoping this is because we're doing a slightly better job, 1% better than the 20%. We're at 19%. Of patients currently diagnosed, only 19% end up in the hospital. So we'll round up just to make the numbers easy. Of the numbers that are in the hospital, I think we're still at about a quarter of those. So I'll give the big picture. 80% can stay out of the hospital. 15% are in the hospital, don't require intensive care unit. 5% are intensive care unit and at the level of requiring intubation. And unfortunately, our mortality is not so great in that subset. About half of them, right?
But the ones who don't require ICU do better, I suppose, right?
They do, and it's this really interesting clinical issue where the first week people seem to sort of putter along, and sometimes there's a tendency to maybe underestimate, say, oh, this doesn't seem so bad, and use that one with the diarrhea again. It seemed pretty mild the first week. But then it seems that during the second week, either the beginning of the second week or the middle to end of the second week, depending upon how healthy, how young, comorbidities, there can be this rapid within 24 hours decompensation. And so we've been really at one of the hospitals where I basically have sort of spent almost all my time the last 12 days, is we try to identify those. We keep track of where we are in the time course. And when we start to see them starting to decompensate, when you see the respiratory rate starting to climb into the 20s, we make sure that's when we move them to a negative pressure room with a ventilator access and in the ICU, so that should they decompensate in those 24 hours, we're ready. We can do early intubation in a calm, planned, non-emergent manner. And then if they make it through that window and start to recover, we're able to move them back out of the intensive care unit.
So have you seen cases of cardiogenic shock after the pulmonary collapse or after ARDS?
Yes. And actually, this is an interesting time course from a clinical point. It seems that first we see the respiratory collapse, patients getting sick enough that, let's say, they require intubation. And then it's about a day or so later that we've been doing echocardiograms on these people, which we're going to have to probably try to limit because I'm not a big fan of having so many people in these rooms in the hot zone. But yeah, you see really, normally when you look at a heart with an echo, it's basically sonar, you see a nice squeeze to the heart, but these hearts are barely moving. And so first you have the issue, you can't breathe on your own. Then your heart's barely pumping, so you get this cardiogenic issue, the heart issue. And then the kidneys start to give out on you. And so these are the severe people that are going in the wrong direction.
It would be nice to know viral loads in the course of this disease, wouldn't it?
That is fantastic. And actually, Stephen Goff and I were talking about this as I was driving in. Steve and I were on the phone. I don't know if people know Stephen Goff, a brilliant virologist. And we were talking about the issue that what I would love to be able to know is, as each day goes by, is the viral load going up, going down, the same way we measure viral load in HIV, even in some other diseases, right? Sure. CMV, cytomegalovirus, etc. Yep. And to be able to look at that, also look at the immune response. Because this is hopefully going to help us with therapeutics at some point, like which therapeutic will affect which patient the best as far as...
Are you doing the diagnostics in hospital? You could do PCR. I mean, it's done routinely for HIV now.
Yeah. I mean, so this is the resource challenge. And so if you think about it, in a perfect world, right, the person would come in, there would be a level of virus in the blood, right? And we'd be able to measure that. It wouldn't have to be sticking Q-tips, up people's noses and then they're coughing and sneezing on the person doing that, which I do not like. But at this point, we don't have an assay or really much knowledge about the level of virus in the blood. So what you'd have to do to track viral load is you'd have to pick a site, maybe the nose or the back of the throat. You'd have to swab that. You have to somehow do it in a uniform manner. So you got the same amount of stuff, right? Because, you're going to get more virus in the vial if you get a big goop. So you almost need it to be a viral load from some sort of a site like the blood so that there's a standard amount of, virus per volume. And then, we have the technology, right? We have the, the qPCR, but at this point, we're running into the issue. We don't have enough qPCR enough to just even make the initial diagnosis to know who has it and has not. So this is sort of our luxury. At some point, we'll actually be where we have the resources to look at this stuff.
So many people are asking us about the test, the PCR test. Can you give us an idea of how accurate you think it is? Is it 100%? Is it mostly? Are there false positives, false negatives?
So nothing is 100%. I was told yesterday there's only 3 things: death, taxes, and then I didn't know what the third was. Apparently it's aggravation. So yes, this is not death, taxes, or aggravation, but it is PCR. And if it's done right and the quality controls are there, it is a very sensitive very sensitive test. There recently was a facility that their initial batch was launched and they had some quality control problems. That's quickly been fixed, and they just recommended that we repeat those tests. So that was quickly addressed. But there is this paper from February which kills me. But so I always like to walk people through it, and it was that the initial PCRs were negative. They don't lack sensitivity. But if you wait a few days, then it'll become positive. And the story was it's Wuhan. They're resource limited. They're basically testing everyone for COVID-19. People show up, and for all the world, it looks like a viral pneumonia, right? But it's COVID-19 negative. So, maybe it's the problem with the test. Maybe it's adenovirus. Maybe it's RSV. Maybe it's influenza. Now, they take those people who are COVID-19 and they put them in the big COVID hospital with all the other COVID people. And check this out. About 5 or 6 days later, they seem like they're not doing so well. And when you test them, now they're PCR positive. Oh my gosh. And, so people are touting, oh, look at the CT at entrance. It picks it up and the PCR is flawed. I'm like, well, I think I know what you just did.
Yes.
I think
I see your problem.
So I think the PCR is great for this moment of time. I mean, PCRs are great for picking up virus, but a negative PCR now will not predict the future. And so if you take someone who does not have COVID-19 and you expose them to COVID-19, a negative PCR does not give you any sort of protection going into the future. Otherwise, I'd be getting negative PCRs just before I go to work every morning.
Yeah.
Many people have also asked us, after people recover, is there some lung damage that persists? Do you know?
Yeah, so I haven't seen a lot of great publications on this. So we're looking at people, and I was actually talking with Justin Aaron just before and Thomas about the fact that we are getting people through this, and and it'll be a question of percentages what they went in with. But you are seeing people come out the other side, intubated, extubated, and doing okay. Actually, they seem like they're okay. I mean, it'll be a while before we see any sort of subtle long-term impacts, but I think that what we're seeing to date is there is a group of people with a short intubation period. They then get off and they do great, but it's clear that there are other people who have, severe acute respiratory distress syndrome, a lot of inflammation. These people, I think we're going to anticipate seeing long-term lung injury.
Okay. So yesterday there was a big splash about hydroxychloroquine. Give us your take.
Yes. I think someone even bigger jumped in the pool, and now we're all wet. I mean that in a completely apolitical manner, but no. So this is, and as I was walking in to see Vincent, he's like, "You look exhausted." I was like, "No, I'm not exhausted. It's just that I just got about 1,000 emails from clinicians saying, should everyone be on Plaquenil? I hear everyone should be, and that's the hydroxychloroquine." And so there's this study, and again, I keep explaining to people, and this might seem silly, but if a study comes out, the title, that's great. You should read the title. I recommend that. But you actually got to read the whole article too. And so
you even look at the data.
But it takes minutes on end to read the whole article. Who's got the time?
And it's painful, right? There's numbers in there. Nobody likes numbers. And so it's funny because Vincent made the comment. He said, well, they just looked at viral load. They didn't look at the patients. They didn't look at clinical outcomes. I was like, well, I read the paper and I looked at the clinical outcomes and they're in there. And so, they start off with a whole bunch of people. They say, okay, this group we're going to put on the treatment arm. And this group, they just said, yeah, I'm not interested. And the people that were not interested, they checked viral loads in them, whatever. They all, stayed in the study. None of them died. None of them got intubated. None of them decompensated. But if you look at the clinical outcomes in the treatment arm, and if anyone looked at this, like one of them dies, right? So we're going to, not going to look at his viral load anymore because he died. A bunch of people decompensate. So I actually look at the clinical outcomes and I say, okay, if I have a choice between being in the treatment arm where people are dying and ending up intubated in the ICU, or the control arm where they actually all did okay and survived, I'm not sure I find Plaquenil so compelling in this study. So I think my take of this is, before everyone gets so excited about a drug where we maybe have 1 or 2 weeks of supply left in the entire United States,
right.
I would actually like to see that it actually not just reduces one lab parameter, a PCR detection of virus, which may or may not be viable and relevant at this point. But I want to see actually that, crazy enough, call me crazy, I want to see that it helps people. I want to see people who took this drug are less likely to die, less likely to end up in the ICU, and more likely to do well. And I look at the data, and I know they're focusing on the viral load, but I'm focusing on the fact that people on treatment, there were deaths in that group. There was a death in ICU, and the other group, there wasn't a death. So.
Yeah. Okay.
What are the sample sizes?
Oh, well, they're huge. They're huge. There were 6 people in the control arm. I mean, it's.
Oh my gosh, so big.
Yeah, 22 in the treatment.
And the other issue is, were the patients volunteered for which arm they were going to be in, didn't they?
Well, that was the great thing. They basically came over and they said, we got this great idea. We want to offer you this therapy. And a bunch of people said, no, thank you. And they're like, okay, that's awesome. You're the controls. I don't think science really works that way.
The people who feel worse are more likely to go for the experimental treatment.
Exactly, yeah.
Right.
So it would, yeah.
Yeah, or the people who feel horrible are like, I feel horrible. I don't want to be a guinea pig. Stop making me look at. So it's not a controlled, right?
So last night on Rachel Maddow, David Ho had the same concerns that you did. No clinical outcomes reported. They do actually report it, as you said, but they don't factor that into the outcome. They just say it brings down the viral load in the patients that stuck with it.
Whenever I agree with David Ho, I feel very good. What is that, like a broken clock twice a day? So that's my got one left.
All right. There have also been some alarms this week about ibuprofen. What do you think about that?
Based on a letter to the Lancet.
A letter, yeah.
Yeah. I mean, and this is tough at this point because, the way I went through medicine is before you gave therapies to patients, we were really careful. There was sort of this do no harm mentality. And it was, before I give my patients something, I want to know that it's going to provide benefit. I also want to know what the risks are. And it does worry me that what I've seen here is this frenzy to do something. And so I go through, like, first the do something was give people steroids, and that doubled the number of people that died, right? So doubled the mortality. So twice as many people died because people wanted to do something. The NSAIDs was the next thing where we saw these reports and limited data, but reports that it seemed like when you give NSAIDs, nonsteroidal, so this is your ibuprofen, this is your Aleve or naproxen, that it seemed that it actually doubled the duration of illness, seemed to even increase the severity. The next was, well, let's give them HIV drugs, right? We'll give them, there's a protease in HIV, there's a protease here. Hey, aren't all proteases made the same? And so what we saw there was no benefit,
right.
But we did see an increase. You put a bunch of people into renal failure, right? So you damage their kidneys. We also saw that about 20% of people with COVID-19 started vomiting. And oh my, that is not what I want to see people do. So I really worry about this trend of jumping in and wanting to do something as opposed to finding out like what will benefit our patients, because this is a new thing we're seeing. We may have used these drugs before, but we never used them here, and it's a little frightening to be, as we've seen, this track record of increasing toxicities, harming patients with this current approach of I want to do something. And now I think there's going to be a frenzy of everyone needs Plaquenil, hydroxychloroquine, everyone needs azithromycin. And I have yet to see the information I need to know, am I going to be harming or helping my patients?
Well, and conversely, the ibuprofen and ACE inhibitor discussion, which was based on this hypothesis that was presented in the Lancet, the concern there is ACE inhibitors increasing the concentration of ACE2, which is a receptor for this virus, which is theoretically kind of an interesting idea, but I think there the suggestion was instead of adding a drug, you might subtract one, but it occurs to me that people who are on ACE inhibitors probably shouldn't just be taken off those, right?
Or, I mean, the nice thing is you could just switch. You know, a lot of times you're choosing between an ACE inhibitor and an ARB, so an angiotensin receptor blocker, which theoretically might have some protection, but we have a track record of managing hypertension with one or the other. A lot of times we make a decision based upon, oh, this person coughed on an ACE inhibitor, they don't cough here. This is cheaper. The drug rep gave me a whole box of these, you know. So I don't see any harm. You know, we're not really, you know, therapeutics. So you say, you know, I feel more comfortable switching my ACE inhibitor patients to ARBs. Fine, that's fine.
Daniel, in this discussion, you've related a bunch of observations that sound, at least some of them, kind of anecdotal. Okay, like, you know, I gave ibuprofen, this happened. I gave something else, this happened. Is there for this sort of situation anything like the vaccine adverse effects resource system where anecdotal observations can be collected to see if there's any kind of trend?
So I'm going to say no so far. And what we're seeing is we're relying on publications. So there was the publication for the steroids that helped us. And that's what we need. The NSAIDs, as I think it was a letter, you know, someone sent in a letter saying, hey, it looks like it makes things worse. And then suddenly we're like, okay, well, we don't really need to give them anyway. So let's just use Tylenol instead. That's completely fine and reasonable. But again, it's, you know, it's not compelling data. It's basically, and you're right. Now, the Kaletra that actually was published, that actually was a study. There was science there, and the science was it doesn't help, and the side effect profile was there, and that was alarming. But no, you're right. This is the day of people reading one-liners and not reading the article, and then suddenly, you know, I want, you know, the call from the family member. I want my mother on all 6 of these things that I read about on, you know, of course, Tech News or whatever website they're sending me a link to.
Daniel, how do you stay informed on what, you know, you think is relevant? Is there some sort of, I mean, obviously there's lots of ways to harvest publications. Do you have a favorite to keep you on point for the relevant stuff?
You know, this is like that Beatles quote, right? Like a little help from my friends, actually a lot of help from my friends. You know, I basically early on realized there was no way that I could keep up with all the literature. So I reached out to a lot of people, and actually we formed a little bit of a consortium. And, you know, Vincent helps out with this. Chuck Knirsch helps out with this. Dixon, you're in there. I don't know if you remember that.
I do.
Yes. Peter Hotez is like, I'm really busy, so we'll bother him infrequently. Justin Aaron. And actually what I've been, you know, this basically saying, you guys, I'm busy in the trenches treating patients all the time. Can you basically help me get through this stuff? And then the stuff that you really think is critical for me to read, let me know, because, you know, this is one of the times when, you know, the silos need to come down and the clinicians really need to rely on people that can read the scientific literature to help guide us, so we don't suddenly, you know, read a one-liner and put our patients on something that turns out to hurt them.
So for many other infectious diseases, there are IDSA guidelines. So Infectious Disease Society of America, do they have preliminary guidelines in this case?
So not yet. And one of the other resources that I remember people always frowned on this, Up to Date, which is not, but they already quickly, and actually it is a great resource. I don't want to, but it's not, it's a good starting place. But they've already created a COVID-19 section, and they're starting to actually update that. I think that is what Up to Date should have been, is constantly updating. But no, I think at this point, we are so early in the process here, and the data and the information is coming out so quickly, so rapidly, that this was how I decided to approach it, was to reach out to what I felt were a lot of really bright people and say, you know, I'll be there in the trenches, I'll share my clinical observations, help guide me as far as, you know, what I need to know, what's coming out of the literature.
So Alan, go ahead.
I was just going to comment on the ibuprofen thing in particular, which was based on a hypothesis that was advanced in the Lancet with no data. Just, hey, this might be an issue. Then got turned into advisories from the WHO, and we have a letter from somebody who got an emergency management agency text, you know, warning the public about ibuprofen based on this theory. So I think that just underscores what you're saying about people reading one line and freaking out.
Yeah, well, I think the article we just discussed, I mean, suddenly that's like, we got to get everyone on plaque window. And I think if you look at the data, it's hard to feel like this is where the resources need to go. I mean, I think the resources need to go on figuring out who has this. The best way to keep from dying of COVID-19 is not to get it.
That's right.
Mm-hmm.
Yeah, I heard a comment from a flight instructor once who said, now, when lights start flashing or something starts going wrong, don't just immediately react, because there's no problem that you can't make worse.
I like that. I like that. We've been apparently doing that to date. We're very good so far at making this worse. We just haven't figured out how to make it better.
Yeah.
There have been some reports of people getting reinfected. What's your take on that?
So I saw that early on, and I never really thought that the information was compelling. And it doesn't make a lot of sense to me. Again, it's like the false PCR. You really have to. And this is hard. You've really got to look closely at how the studies were done. And, someone's sick, and then there's a negative PCR, and who knows? And because as we know, it's a procurement. You have someone to stick that in, get a proper sample. Now it's positive. Oh my gosh, they're reinfected. Will there be a tiny percent of people that can get reinfected that fail to mount a good immune response and get neutralizing antibodies? Sure. And there's no reason to think that will be anything more than quite the exception.
Yeah.
But as we know from coronaviruses since the 1960s, when we this is not a brand new family, and now from SARS, at least MERS, it does look, and actually there is some data even here that people develop neutralizing antibodies. So these are antibodies that protect you. This is why the virus goes down. And if this acts like MERS and SARS, those neutralizing antibodies should last out to at least a year.
Right.
I don't know if they're going to go beyond a year. I'm hoping by then we've got our vaccines. That's what I hear when I read the press. No, because that's disastrous if you can't get at least long enough lasting immunity to get us to a vaccine or to get us to a point where we have a therapeutic or a prophylactic medication. That's going to be disastrous.
Well, Ralph Barrick said last time that probably the original coronas that are just common colds, they originally spilled over many years ago. They caused serious disease, but we didn't know it at the time. There was no medicine. And as the population got immune, they got reinfected, but mild disease. And then it's just the kids that keep getting infected, and they get very little disease. And he said this will probably end up having the same kind of pattern.
Yeah, it's interesting. I don't know if people know this commonly, but when someone comes into the hospital, we do they call it a respiratory viral panel, an RVP. It doesn't just check for viruses, checks for, some bacteria, mycoplasma, chlamydia, a few others, depending upon your institution. But it actually looks for those 4 common cold type coronaviruses. So I actually see people on a regular basis. I see adults, right, above 18. So I actually see adults commonly come in sick enough to be hospitalized from the common cold coronaviruses, but not sick enough at this level that I'm seeing with this coronavirus.
So do you think this one will be added to it at some point, right?
I hope so. I mean, it makes so much. Actually, it in a sense has been added as far as a workflow, at least from the pro health side, is we stick the swab into your, deep into your nose. People feel like you're biopsying my brain. Now it's been done correctly. And then that goes into the vial with the viral transport media. And that fluid, which now has whatever virus, gets aliquoted. One aliquot goes into the COVID-19 PCR assay, and one goes into the multiplex RVP assay.
Yeah, here are the viruses, as you say, adenovirus, all the coronas, those 4 coronas, metapneumo, rhinos, flu, paraflu, RS, and then some bacteria.
Daniel, out of curiosity, what's the technology in the respiratory panel?
It's a multiplex PCR.
Okay.
Yeah.
The funny thing was having to explain to people that they had the other coronavirus. That was a bit of a difficult conversation.
So there's
Daniel,
Yeah.
Oh,
Go on, Brianne.
Do you think that the evidence of immune responses would be reason that people could be treated with convalescent serum?
I was just going to ask that.
Yeah.
But I was going to also contribute. There's a website, the Johns Hopkins website, of course, and on it I found a recent letter to the Journal of Clinical Investigation with all the good arguments for and against that. So I'll send you the reference if you'd like.
It's Arturo Casadevall.
That's the one. That's the one.
That's a good paper. I've given up sleeping, so yeah, I read that. And it's interesting because I was looking for the data, but it's more of sort of a concept. It seemed when I read it.
Exactly.
And but no, this is something, right? Ebola. This is a lot of like, what is the first thing you can do as people who have recovered, who have neutralizing antibodies? If you can somehow purify those and not give anything else with them,
yes,
right?
It's important.
Yeah.
It's interesting. They left out the Sentinel article, I thought, on the use of convalescent serum in these emerging infections for Lassa back in 1968. That isn't referenced in his letter, but he should have.
Yeah, it happened here, right?
Mm-hmm.
It happened right here.
Yeah.
Yeah. So no, I think Gale. Yeah, no, that's a sort of a quick and dirty, but very limited, access thing, because you've got to find these people. You've got to identify, isolate, purify the neutralizing antibodies, and it's hard to get large amounts of those. Just the whole process is the challenge. But there actually are people, and maybe Ori's going to jump in on this, who there are ways, instead of just collecting them from people who've been sick, to actually bioengineer neutralizing antibodies, which I worked on this for a while and found it incredibly painful. But Ori?
No, I didn't. But I know that Regeneron has a neutralizing monoclonal that's going into phase 1 here, I believe. Have you heard about any other examples of that?
There's actually several people working on it. That's the one I think that is getting the press. And I used to actually do this. This was maybe why I came here to Columbia. I would sit in this special room where I would have isolated single B cells, and I would clone and make antibodies. And I was the only one in and out of that room because it was RNA involved and things could break down very quickly. And you do that for a number of months, and basically I was like, I will go insane. So no, I mean, the people that are going to help us generate these, the technology is there. I feel like my job's hard at times. You guys, thank you.
So now you know how Gus Nossel felt.
How are you doing on PPE? Are you running out?
So I have
PPE for the listeners is personal protective equipment.
Thank you.
Oh, thank you. I was wondering. No. So I must say, different hospitals have approached this differently. The main hospital that I've focused on, I sort of picked one hospital. I said, okay, I'm going to try to make this hospital as much as I can, a center of excellence, we'll say. And so it's a hospital where I had spent a lot of time and knew a lot of the staff. And so a couple weeks back, actually, seeing this coming, I started really going through and saying, okay, let's talk about how we approach our supplies. Let's not have everyone and their cousin using these things because we're going to run out. Let's make sure we have enough supplies because we don't know what the reorder is going to be like. And at that one, it's a Northwell hospital. It's Plainview Hospital. I have to say, I really feel safe and comfortable going in there. We the nursing staff, I was there last weekend, and they were going through retraining everyone, making sure everyone felt comfortable, going through how do you properly care for personal protective equipment, how do you properly gown and degown, how do you minimize blood draw so that we're not overutilizing the finite amount of supplies we have now before reorder. And so actually, as a model, I have to say that hospital has done a fantastic job. Unfortunately, a lot of other hospitals are getting to the point where they say, okay, see this flimsy surgical mask? You've got to wear that all day. And you only get a new one, under certain circumstances. And I really worry about that because as we know from that aerosol, if you do an aerosol producing procedure, so you go in there, you nebulize someone, you intubate someone, if you get this stuff up in the air and you breathe without a respirator, without an N95 mask, you're going to get sick. And this is bad stuff. So this is a huge challenge and concern for me as a healthcare worker.
So someone put in a
that's
question
me.
Here. Go ahead.
There was a clip in the paper this morning about a 2-mile long line for driving testing in Houston, and it made me wonder. I'm imagining a lot of these people who really don't need to be tested, and in particular as a public service announcement, but also out of curiosity, at what point is it appropriate for somebody to seek a test?
That's critical. And so at ProHealth Associates, where I'm the chief, it's nice to be the chief sometimes. So, we established a COVID-19 hotline. And so people don't just show up. People call the hotline, and they are triaged to a medical professional. And early on, the doctors, and I think they're still a little bit annoyed, I basically have about 1,000 doctors working for free, or most of them, because they're on the phone and they're talking to people, and they are going through and saying, okay, you're 22 years old, you're feeling a little crummy and achy and your head hurts. I'm sorry, I'm deprioritizing you. Just take it easy. And when we have more testing, we will get to you. But when, the 78-year-old woman calls in with chronic lung disease and heart disease, who's providing childcare for her working daughter, and she says, I've got a high fever and I'm really having trouble breathing, she comes in and we do our drive-throughs by appointment. I don't want, 2 hours of people in cars waiting, because some of the people show up and they're pretty sick. And so we don't have a technician do the testing. We have, once they make it through the triage and we determine that's the best place for them to go, a clinician actually looks them over. We've got vitals. We determine, are you appropriate for drive-through testing? Do we need you to pull you over to the side? We have sort of a brief triage. Or do we bring you into a facility? So we do all our testing at urgent care should they need to be brought into the facility. Or on the phone, they're triaged straight to an urgent care, or in certain cases, triaged directly to a hospital. But that clinician has called ahead, and the patient will, let's say they go to an urgent care, they go to the hospital, they will wait in the car. There'll be a phone call, and there's no waiting room. The patient goes from car to private room and gets assessed.
Okay. So the answer is call first.
Yeah, or you're going to jump in there?
Yeah. So 2 things about expanding number of beds. So have you seen any information about increasing bed capacity out on Long Island? And then second question is, are there tents being built? So NYP announced today that there will be tents at several of the satellite hospitals to be used as fever clinics, essentially, to expand capacity.
I think that's the next natural step. I mean, I saw an article in Forbes this morning. I should probably just sleep and stop reading things. and it was, they're bringing this 1,000-bed hospital Navy ship. It's a beautiful ship, right? Yep. They're going to bring it here. That's going to give us an extra 1,000 beds. The parent company of Pro Health Associates is Optum, and they have an arm, OptumServe. So I've already been talking about, can we basically bring in, you don't really want a party tent, right? What you really want is a military tent. I mean, we can get great deals in the party tents because, right, it's illegal to party, but congregated mass. But bring in these big medical tents because, if you put a lot of people, you need bathroom facilities. Mm-hmm. You need, places to plug in the ventilators because, you're not bringing people in just because they feel crummy. You're bringing in people who might need intensive care units. So, the whole concept, and we've been talking about this and now we're getting a little far along in that, but we're going to need the capacity. And we're hoping everyone, basically jumps up. I would love people to look back and say, wow, you guys sort of over prepared and over responded and it was not as bad. I'm hoping it's not as bad because we respond with the intensity that we need.
What I heard about the ship was that it was going to be non-COVID-19 patients, but all the other patients that need some kind of care.
I heard that as well. Yeah.
Yeah, no, Kathy, that's what I heard. And the idea, and this is our challenge that we're already thinking about, is how do you make sure you don't send a COVID-19 patient onto the ship? So we need, right? So we need rapid testing and some sort of a process so that your turnaround time is quick enough that you can test someone, make sure they're COVID-19, and then maybe even sort of a stage where initially they're in one part of the ship should people, have come in the prodrome and not yet be shedding virus. And so I think that's going to be a big challenge. But yeah, that's the plan. And, and people are like, oh, you can't, we can do things. This is,
So Daniel, of all the people that you tested that had symptoms that thought they had COVID-19 rather, how many actually turned out to be positive?
I hate to say this because my reaction to this is we're not testing enough people. I know that I got the numbers for the Northwell hospitals. It's about 40% of tests have come back positive.
Yeah. 40.
40%.
So you think you're seeing a lot of flu too then?
So here's interesting. I think this is really important. One of the first patients I saw, and it was an urgent care clinic, and I was setting up back in February and basically saying, I'm going to go through this process. I'm going to watch you, and I'm going to make sure that people come in and out in a safe manner because I don't want my staff sick. And so this is Adam Fitterstein. He's the chief of urgent cares for ProHealth. And so the patient comes in through the side door, and the story is that this individual was at a tech conference here in the New York area. The person that he had lunch with is now been told he's COVID-19 positive. The man was coughing and sneezing at the meal. And about 4 days later, this gentleman started to get fever, started to get body aches. Now he's having some trouble breathing, and he wants to get tested. And this is actually at a point when we had not had significant access to testing. So the man comes in. Adam does the rapid flu. He's like, hey, Dan, flu A, we're done here. And I'm like, Adam, you're not done here. You're not done here. You stay in your protective gear and you continue. And so he did the respiratory viral panel. He did the COVID-19. We stored the COVID-19 test on ice, right? Because we didn't have access yet. And when we got access, we sent off the test and it was positive. So when you look at the numbers in Northeast China, where they actually had a little more resources, I'll say the majority of COVID-19 patients, it was during a flu outbreak. The majority of them also had the flu. So COVID-19 infection does not magically protect you against other viruses, and other viruses do not provide magical protection against COVID-19.
That it addresses something we talked about last episode.
But when you've got them both together, what are your expectations? I mean, have you got any data on that?
That life sucks. I'll tell you the data.
Oh, I imagine that.
Yeah, and so the data again, the data you've got to look through how it was generated, and if you look at Wuhan, they'll tell you that the people with co-infections did very poorly. But if you look at the way the protocol ran, you got COVID-19 testing, and if it was positive, okay, it was positive. But they were not doing early on the COVID-19 if you had flu A, if you had something else. So let's say you had influenza A, and you're documented, you're not doing well, you didn't get COVID-19 testing. But let's say you had influenza A, and now you're on a ventilator, and it's a couple weeks, and you're not getting better, and you say, you know what, I'm a senior doc, I really want that COVID-19 test, and a couple % of people got a COVID-19 test even though they had another diagnosis. And yes, then you had this, 2-point-something%. And guess what? They did really poorly. Well, the only people that got tested were the people who were doing
were the ones who were sickest.
Right.
Yeah,
Right.
So it's really hard when people quote numbers. You got to say, all right, let's read the study. I know this is going to be painful.
But that gets at a fundamental issue with a lot of the discussion that's going on, and these papers, of course, get tremendous amounts of coverage. Where this group is affected or that group is affected, and this is surprising. In this country, the epidemic is going differently than it did in that country. But it seems to me that a tremendous amount of that is stemming from how bad the data are, because we just, certainly in the U.S., we've done nowhere near enough testing, right?
That is true. I refer to us smiling doing the testing as turning the lights on. A lot of us that have been watching this have felt that, yeah, it's been here. We've had community spread since, February at some point at least. And we, actually, Governor Cuomo got on. I got on sort of a little bit afterwards, actually. He was saying you're going to see thousands of reports of positives in the next week. That does not mean it blew up. That means that we are confirming what we've been telling you. Exactly. And I echoed that, and I echoed it after him. I said, that's what it is. It's not that suddenly there was an explosion of cases. The case numbers are not doubling per day. This is how many cases. Now we're going to know who has it. We're going to know where they are. We're going to be able to address it. So this is reassuring that when you see the numbers.
I warned people about that on Twitter a week or so ago, too, that the test is becoming available. The numbers are going to go up. It doesn't mean anything's new. It just means we're sick.
And what about secondary bacterial infections? Do you see that at all?
So it's hard to know, right?
Right, sure.
Yeah. And so, and actually, there's no reason why you wouldn't. And I find it a challenge to look at a patient. And a lot of patients, I feel pretty confident. I say, I don't see evidence. I don't treat with antibiotics. I try to and I've got a little macro, no antibiotics unless, compelling evidence for a bacterial secondary or super infection. There are certain situations where it does seem like that is the case. Maybe we'll get a sputum, it'll grow a particular pathogen. This is one of the cases where I think it's nice to know what you're doing and not just routinely give everyone antibiotics. But no, that's an excellent.
But you're seeing some.
I'm seeing some that I believe are co-infected. Yeah.
So there are a bunch of links here about, I think, pregnancy in COVID patients. So last time someone asked us if it would be a good idea to get pregnant during this.
I want to become young and pregnant. No, I really just want to become young, I think. But, early on, there was a lot of fear, I guess I'll say, and a lot of concern, because if you look at what happened in H1N1, if you look at what happened in SARS and MERS, pregnant women were about 5 times as likely to have bad outcomes. It was really a significant issue. And the first report I saw out of China was really they just looked at a sample. They took 9 pregnant women and they said, let's compare them to age-matched controls. Let's see how they do, because you expect them to do better because they're young. You expect them to do worse because they're pregnant. Yeah. They seem to do as well as the age-matched control. So far, I have not seen anything that is not reassuring in terms of being pregnant. I have not seen any signal to suggest that they're a special high-risk group. No, but I say I haven't seen. But again, as I came in here to talk, a paper may have been published in the last, or maybe Ori read something that he's going to start updating me as well. So.
No. Well, the 2 papers that I posted, and then Kathy posted 3 more. So the 2 that I posted were with ends of 10 women, more or less. But there was no evidence for vertical transmission, and then the women were mildly affected. So. Yeah, but it's so few women.
Well, 10 and 10 and 9. Pretty soon we're up to 29.
unless they're counting the same one over and over. But also they did some comparisons with pregnancy during SARS and MERS infections, and things do seem to be less severe. And the clinical characteristics in one of the studies were very similar to non-pregnant adults that had the disease. And as Ori said, no evidence of vertical transmission, either intrauterine or by breastfeeding, which seems a little weird because then they talk about babies getting separated from the positive mothers for 14 days. But they don't find evidence of virus in the colostrum. But again, just very small sample sizes.
And there was also a letter of concern in JAMA about that many patients are being analyzed in multiple studies repeatedly from Chinese cohorts. Right. So there are a number of problems with these patient populations in retrospective studies, especially.
Right.
Once again, for the listeners out there, by vertical transmission, we're talking about is if a pregnant mother gets sick, is the fetus at risk? Right. Or if you're breastfeeding, is the child at risk? And what I'm hearing is that at this point in time, there's no data to suggest that that's a problem, right?
Right.
But there aren't enough data to really say for sure.
Right. And there was one thing that indicated that some of the tissues at the maternal fetal interface have low ACE2 receptors. And so that might be a factor. That refers to some published results. Oh, go ahead, Brianne.
So you say there's no evidence for vertical transmission. Are the babies otherwise healthy as well?
Yes.
Yeah. The APGAR scores for whatever prognostic value that have were quite high for both in both studies.
Okay. Right.
Good.
Right. We used to think Zika virus was of no concern to pregnant women too, but
yeah, I'm worried that if there's a big cytokine storm, that this is going to affect the fetus in some way.
Yeah, I'd almost worry about first trimester stuff that we're not going to see for a long time.
Right.
Right? So,
absolutely, yeah.
Okay.
Right.
Would you mind? You want to go?
Yeah,
okay,
I'm
Ori.
going to step out. Thanks, guys.
Thank you for
Thanks,
joining
Daniel.
us.
Thank you.
If you're around next week.
Oh, it's Ori. Ori's leaving.
I'm leaving. Yeah.
Sorry.
I'll be here next week.
Okay.
Yeah.
Bye-bye.
Bye-bye.
Stay safe, right? That's what we say now.
Yeah, stay safe.
Absolutely.
Yeah, stay safe.
We want to help us answer some emails, Daniel. Is that good for you?
I'll hang around and answer them as long as someone else does the reading.
Yeah, I'll read it. No worries.
I'm reading too much.
And we've streamlined our email process.
Just 2 things before we do that. First, this is kind of interesting. Second dog infected in Hong Kong. And Ralph Barrick last week said he's worried that a lot of animals have human-like ACE2 receptors and that this could go back into an animal and make a new reservoir. He said including bats, which is not good. So the infection of a dog is of concern, I think, even though it's only 2. But.
Yeah, I wish this paper had come out sooner because I came home last night and there's a dog in my house, a second dog. Right. And I'm like, what's going on? And apparently, so we raised a dog for canine companions. And then after the dogs now went off to university. But canine companions had to basically shut down and evacuate. Oh. And of course, my wife was right there to take one of those dogs. So now I've got another dog.
Well, yeah, if you're sick, I would be careful of your dog. We just don't know, but
we're social distancing. I'm like,
social distancing
from the dog. Good luck with that.
I also want to.
One of our cats is pretty good at social distancing. But
yes, they are. Cats are good at that. So I want to cut in now a talk I had yesterday with Valeria Cagno, who is in she's from Italy, but she is working in Switzerland, and gave me an update on what's happening in Italy and Switzerland. So we'll listen to that. Returning to give us an update on what's happening in Europe, my guest today is Valeria Cagno from the University of Geneva. Welcome back.
Thanks for having me again.
We have talked not too long ago, but things have changed massively, haven't they?
Yes, a lot.
So let's get an update, both in Switzerland and in Italy. Wow, I'm looking at the numbers. Italy has got almost 36,000 cases so far, right?
Yeah, it's still increasing, so we are checking the update day by day, hoping to see a decrease, but it still doesn't happen so far.
Do you think it will surpass China, which had 82,000 roughly cases?
I hope not, but I mean, seeing that the increase is around 4,000 per day, I mean, still it's far. But the problem is that the majority of cases are actually in Lombardia and in the regions of the north. So it's not like all Italy. And the problem, I mean, what the people are fearing is that the virus is starting to go to south. And there, I mean, I hope not. So, I mean, there is potential for further expansion, let's say like that, but I hope it won't happen.
So mostly around Milan, is that the area that's involved?
So right now the provinces that are, Milan, and then it's Bergamo, Brescia, Cremona. So these are all cities in the same region. And where it started, it was another province that was the first red zone was made. And actually there the number of cases is stable, it's not going that up. So right now it's really Bergamo, Brescia, and Milano that are the ones that are more scary. But also in the neighbor regions that are Piemonte, that is actually my home, the region from hometown, is going up. And also Emilia-Romagna, that is a bit south. So it's still clustering in the north, let's say.
Mm-hmm. So are there cases in Florence yet?
Some, yes. But because, it's not that far. But I think everywhere in Italy there are cases. Also because a lot of people from the south goes to work to the north. And that was one of the massive polemics that there was when there was this shutdown first of Lombardia and then of all Italy. There was a lot of people taking all the trains to go south, and this was the worst thing to do ever because I mean everyone was scared about the virus going south, and then they were saying when they arrived in their hometown in the south of Italy, they declared to the health authorities that they were coming from Milan and they were put in quarantine. At least that.
Have there been any cases in Sicily yet, all the way down there?
Yes, I think the only province where there are no cases so far is Isernia, but it's I don't think a lot of people know the city, but all the other regions and provinces in Italy have cases.
So do we understand why Lombardy is the problematic area?
No, the real answer is no. So there are several guesses. I mean, it's probably where everything started, and then it just diffused fast, and then it's still being transmitted. And
so,
there is now a bit the story of this little village in Veneto. That is the other original cluster of cases that is called Vo Euganeo. That was where the old man playing cards died. Was one of the first in Italy. And there was the University of Pavia did a study to see actually also in asymptomatic patients. Basically, all the little village was had a swab, and they say that 75% of the people that had the virus were asymptomatic. So I didn't see the data yet. I just heard the people from the University of Padua talking about it. But that's also what they are claiming, that the data from China are not true, or I mean, at least from what they see. And the reason why there is so much spread is that there is a lot of undetected, people feeling well and going around and spreading the virus.
Yeah, that's what we've always thought. And China said no, and even WHO has said there's not much asymptomatic spread. But I think that's not true, because that's probably explaining why it's spreading so quickly, right? Because there are a lot of infections already established.
Yeah, it makes sense, but I would like to see the data and understand why there is the discrepancies between what China said and what WHO said as well.
So you say in this one area they did a study and they found that. Is that going to be published at some point, do you think?
I hope. I tried to contact the author of this work, but so far I didn't have any reply, because I would like to, interviewing for my podcast as well. But, I hope to see that. And then it's in line with some modeling that were published in Science, I guess, recently as well, that there are a lot of asymptomatics. So what it says is that exactly when the first case came out, they decided to sample all the people. And then 10 days after, they did it again. And actually, since they shut down everything, there was a significant drop in the number of positives. And actually what he also said, but I want to see the data. I'm just trusting what I heard at the radio. It says that it's not actually, there is no correlation between being asymptomatic and having low amount of virus in terms of qPCR.
All right.
But
I hope we see that.
Yeah, I want to see it as well.
So you mentioned everything is shut down. So what exactly is going on there?
So in Italy right now, the only things that are open are the supermarkets and only the parts. So if you have a big supermarket that is selling, for example, clothes or something like that, this part is closed. So it's only for food. And then pharmacies are open. And not a lot more than that, I guess. All the rest is, and then you can go out just for going. To buy groceries or to the pharmacy, or like for jogging. But this is even not clear. So now some parks are closed as well, because there are still people around, and they are trying to limit as much as possible the people around. And you need to have a certificate in case the police is stopping you, saying why you're in the street. So like, I'm going to the supermarket, or I'm going to the pharmacy.
So you can't just do a passeggiata, huh?
Yeah. And then there is, of course, if you have a dog, you have to walk it out. There are some exceptions, but normally there is no good reason to be out except for these reasons, let's say. And
how do you get the certificate? Do you know?
It's so you can print it from the Italian ministry website. And then it's just like a declaration that you do, and in case someone stops you, he has your written declaration that this was the reason why he finds you around.
I see. And what about public transportation? Is that all closed as well?
It's not all closed. There's like, for example, all the buses are doing weekends shift, and there are a few trains still going. Because, for example, sometimes you need to go to a hospital or to go. So there are some necessities, and so that's why it cannot be shut down completely.
Mm-hmm. Do you have any idea how long this shutdown will continue?
No. I think the original the decision was the beginning of April, but it would be for sure prolonged.
So right now it's indefinite.
let's say so. Yes, I mean there is not an official ending.
So over here, we've been hearing horrific stories about all the deaths. You have almost 3,000 deaths. What's going on there?
So again, there are different theories, but let's say the one that I trust more is that the number of cases is actually underestimated because they are not doing all the tests. So if you start to have symptoms, what they say is like, okay, if you have fever, you're coughing, just stay home and don't go anywhere. And unless you really cannot breathe, stay home. And they don't even do the testing. So this explains why the death rate is so high. I mean, it's not that, it just tells us that there are a lot of cases missing. Also people with symptoms, we are not talking about asymptomatics. Then it's true that the majority of cases are in these provinces and the hospitals starts to be saturated. I tried to speak with some doctors in Cremona, and they told me that they are not yet at the very limit, but still it's saturated, and they're building new hospitals, temporary hospitals in Milan. So there was a huge crowdfunding on Facebook and other social media done by, so it's a couple, she's a fashion influencer, the name is Chiara Ferragni, and her husband is a singer, let's say, that is famous in Italy, and they started this crowdfunding, and they had, I don't remember, but it was a huge amount of money, and so they are building this like temporary hospital in San Raffaele, that is an hospital in Milan, and as well the state is building another temporary hospital using what was the old Milan Fair. So they are trying to increase as much as possible the number of ICU beds and trying to at least ameliorate a bit the situation.
So here we're told that there are either not enough ICU beds there or there are not enough ventilators. Are either of those true?
I think it's depending from region to region. So as far as I understood, it's true that in Brescia, Bergamo, it's something that is happening, that there are not a lot of ICU beds available, nor ventilators. And there was also the news, they were discussing the fact that sometimes you have to decide for who to use the ventilator, so who has more chances to survive according to age or to other pathologies. But this is not formally written, but it's probably what is going on. But this, I mean, I'm not there and I'm not a doctor, so I cannot say for sure, but this is probably what is going on.
So of the 3,000 deaths, are they mostly in older individuals? Yes,
so this is something to take into account. So the population of Italy is quite old. So for sure, the number of deaths can be, it's high also because of that, because it's a quite old population. And they were saying now that I think there was a median age of 80 years old or something like that. It's not the most updated that I can remember, but still, I mean, the majority are old person and with other pathologies, so it's not, normally they are not healthy patients, let's say.
Mm-hmm. So here in parts of the world, we're starting to hear about testing of a variety of antivirals, and the most recent one that I'm sure you've heard of is chloroquine.
Yep.
What is there anything going on there in similar way?
So I know that. I saw the results of the lopinavir-ritonavir trial that doesn't seem to work well. Mm-hmm. But this is in China. In Italy, what they were talking during these days, they are giving this remdesivir. I hope to pronounce it correctly. But right. Also they are trying to use as well this anti-IL-6. So it's a monoclonal antibody that is apparently helping when there is this severe pneumonia that is also linked to inflammation. Therefore, having a way to reduce inflammation seems to work. It was already used in China, and they started to use it in an hospital in Naples. And then Roche, that is the company that has the drug, that is tocilizumab, it should be this the name, decided to give it for free for a trial, and so they started using it also in other hospitals. So this is another drug that is currently in use.
So it's in a trial, or is it just being used?
I mean, it's in a trial, but there are reports from China saying, they already used it there, and apparently it showed some efficacy. So there is an official trial starting in Italy as well. Okay.
So last time, which was, let's see, it was March 4th last time I spoke.
Seems so
I said gosh, it seems forever. I asked you how people in Italy were reacting, and let's ask it again. How are they reacting? Are people panicking?
A bit. When I call my mom, she says it's weird to see all the city completely empty, and then you go around, and if you don't have the face mask, people stares at you like, "Oh, what are you doing?" But then there are few pharmacies that have it, and they're not panicking, and they're accepting. I see also on social, Facebook and others, people are writing to everyone, stay at home, the cases are still increasing, you cannot keep going out or finding excuses for a walk or for whatever else. We need to try to stop it. So there is awareness, there is at the same time a bit of panic also, because there are these, so we use a lot WhatsApp to exchange messages and things, and there are a lot of audio messages or written messages that you don't know where they're coming from, and the majority of the time are fake news, and they start to spread, and sometimes you have to reply to people saying, no, this is a fake news, you don't have to believe whatever comes from WhatsApp, try to find the source of the information and believe only to what the official WHO and the Ministry of Health are saying. So there is a bit of everything as that's normal.
So are most people obeying the restrictions?
I think so. Again, I'm in Switzerland, so I cannot go to Italy. I think I can in theory, but then it will be a problem to come back. Yeah. But as far as they are saying to me, the majority is. There are still some cases, especially in the south, where maybe the people are not really realizing what is going on, because the number of cases is not that high, in which there are also news of someone that organized a picnic in the park for 12 people and then got arrested, or other weird stories. But the majority of the population is really obeying, let's say. Yeah,
you might have seen photos from the U.S. of students on spring break all congregating at beaches.
That's a very good idea.
Oh, it's just crazy. So you mentioned Switzerland. So what is the last time you said they weren't restricting travel? What's the situation there now?
So right now they changed, I think it was Sunday. Friday they announced the schools were closed. Monday they announced that all the shops except pharmacies and supermarkets are closed as well. But then there is no restriction of going around, so we can still, for example, go walking or hiking or whatever else. And there is the restriction of not being more than 5 in groups. And I'm still going to the lab because we are working on coronaviruses, but for the rest, the university is completely shut down. So it's a bit weird to be in the university alone. And then about traveling, the borders are closed and you can enter. So both from the French side, because Geneva, where I'm living, is close to the French border. So both France and Switzerland closed the borders, but there is still possibility to cross in case you are working because there are a lot of people living in France and working in Geneva. So in that sense, it's possible to enter if you have a certificate from work saying that you're going to work.
Got it. So, restaurants still open?
No.
They're closed. So everything is... But people don't have to stay in their homes, you said, right there?
No, there is not this restriction by now.
Well, looks like you have just below 4,000 cases in Switzerland.
Yes, but they're increasing, and again, there are some areas where there are more cases, and I had just heard, I think it was 2 days ago, from the hospital of Geneva, and they were saying we had 7 people in the ICU the day before, and then they became 15 the day after. I mean, it's starting to ramp up.
Yeah, I'm sure it'll increase, as it is going to everywhere, right?
Yes.
I'm sure that it is. Well, last thing I want to tell you, we got an email 2 days ago from Sophia, who's one of our listeners in Greece. And she specifically asked about you. And we actually have addressed a lot of her questions, about why there's so many deaths there and so forth, the aging population. But she says, I am very sad with the death toll in Italy. Greece has started lockdown after the first death. We cannot afford to be Italy. Our health system is already stressed as everything else in the country. I guess time will show who acted best, given the country's circumstances. And she says there's plenty of toilet paper in Greece. Do you have plenty there in Switzerland?
No, actually, I was laughing when I heard one of the last episodes when you were talking about toilet paper in the US, because when there was this announce of closing the schools on Friday, then on Saturday we went for shopping, and actually what disappeared was toilet paper. And then there was no pasta. So the two things were not milk and toilet paper as in the US, but were pasta and toilet paper. So we had it, so we didn't need to buy it, but they are still telling me that there is some shortage of toilet paper here as well.
Wow. And she says, P.S. Paziente Zero is a nice podcast, highly recommended if you speak Italian. So this is from Sophia. I suppose Sophia in Greece speaks Italian.
Yeah.
Must understand it. So you got a letter on TWiV for you. How about that, huh?
It's pretty nice.
Yeah, it's good. All right, well, that is great. Valeria, right?
Correct.
I keep forgetting. I don't know why. I have to talk to you more often so I'll remember. Valeria, that was been great. Let's plan to come back in a couple of weeks again, if it's okay with you, and we'll get another update.
Yes, sure. I'd like to participate again.
Yeah, all right. So stay safe. Good luck with your research, and talk to you soon.
You too. Bye.
Bye. And then she gave me a link to an Italian site, and it is in Italian. So if you speak Italian, it's good. It's from the Istituto Superiore di Sanità. It's kind of like the I don't know, is it the FDA of Italy? They approve polio vaccines, for example. So I used to know someone doing that there. Anyway, they have a page here on surveillance, sorveglianza integrata COVID-19. Anyway, so it's all in Italian. You can copy it and paste it into Google Translate, but there's one infographic in English, which is really nice, which gives you a picture of what's going on in the entire country. So you can look at integrated surveillance, and they have symptomatology, number of cases throughout the country, breakdown male and female, and age as well. And, here, the CFR, it's interesting, 0% in the young ages, and then 80 to 89, 80 and above, 20% CFR. Anyway, if you want to look at the Italian numbers. Okay, so we have a listener from Norway who is sending us a visualization of European CDC data. I will just take a couple here and then pass it off to someone. This is Our World in Data, which I've seen before, and it's a good site. Thank you, Sindre, Sindre. And then this is very interesting. We'll get Daniel's take on this. So Mark writes, as Mark has written before, he's the CEO of Quality King Distributors. I don't know if that's a supermarket chain.
COO, Chief Operating.
COO. Well, either way, high up, right?
Yeah.
He says, TWiV, please read this. We must stop the government for needlessly collapsing the entire global economy. And it's an article in Stat by John Ioannidis, who is an epidemiologist at Stanford, who argues we don't have the data to be doing what we're doing, which means, shutting down everything and so forth. He said we should have the data. We don't have any at all. And should we be doing this? And He is this. I have to remind everyone, we have talked about him before on TWiV because he had a series of papers a number of years ago saying most science cannot be reproduced. So Daniel, his suggestion is we shouldn't be doing this. We shouldn't be the distancing. We shouldn't be shutting down schools and businesses until we get the data that we need.
You know, it was last week when the superintendent of one of the largest school districts in Texas gave me a call and basically asked me, so, Dan, what are you thinking? Someone I've known, oddly, who calls me during times like this. And I said, well, you really, I think it's pretty clear. You have two choices here. You can either close the schools now or you can wait till it's too late. And it was because I listened to TWiV, you guys, and gals, so Kathy and the gang. I think I've been listening all along, and it's been interesting to follow the discussion about, what did the Chinese do? Was it draconian? Was it too much? But now, if the data is to be believed, it looks like after a number of months, it's under control. And so it's hard for me to criticize moving in the direction where we're trying to stop the spread, flatten the curve, and waiting until we have the numbers, which unfortunately, as clinicians, you have a pretty good sense just watching what's going on in your patient population, waiting to have it confirmed, which has been taking weeks from when we saw this in February, about a month now, which is really... That's too long. Back in February, when we first started to suspect and see the signal, would have been a great time to respond early. And maybe that wouldn't have had this horrible impact on the economy because, about 20% of people are going to be sick enough to be in the hospital. 80% of people are not. But everyone in America is going to suffer and is suffering from this virus, whether they catch it or not. And that's unfortunate that we're in this situation.
Well, actually, Rich and I had a conversation, an analogy, because we both are sailors, and actually Vincent is too. You can reef the sail when you think the wind is kicking up, and you can say, well, should we reef it now or should we wait? And if you wait, it's going to be a whole lot harder. If you reef it now, the downside is the boat slows down, and maybe you didn't need to. But it's probably better to reef now anyway, because you'd rather have done that and not need it than the other way around.
Daniel, you like that analogy.
I like that. I'm an avid sailor, as maybe people know. I'm trying to figure out, should I get my boat in the water really quickly before I can't?
How many do you have?
Yeah, just to elaborate on Alan's, my skipper and I have a pretty conservative approach to things, and we made an agreement some time ago that the first time either of us even starts to think that we ought to reef, we reef.
It's time. Yes,
it's time.
Yeah, no, I may have to buy a larger boat so that I can social distance between the person at the helm and my jib sheet trimmer. And
so, Daniel, you mentioned something that interests me.
Just one thing. Everything else, but there was one thing.
You in passing in this discussion, you mentioned, your perspective as a physician, okay, without any testing or anything else, your boots on the ground, and you can see stuff happening in the hospitals, in the emergency rooms, and et cetera. From your perspective, it sounds like this is very real. Something's really going on here.
Yeah, it's really real. And it reminded me of talking to, it's the dean of NYU School of Medicine where I went, and it was Saul Farber. And we were talking about, the early days of the HIV epidemic. And he was saying, this is just not right. And I'm looking at what's going on, and it's acting like there's some sort of new infection that has entered our community. And sometimes, people that notice that, and I think early on, as we heard about the physician in China, people are like, you're being an alarmist. But, when you have a clinical impression like that, and a few people start to have that clinical impression, I think this is another case where, in retrospect, it would have been great if we all jumped on board early before it got to where it is now.
Right.
Alan, can you take Eric's
Sure. Eric, just going to read the highlights here. A key constraint on respirators is the need for beds that are attended to by nurses and other hospital staff. You need a certain number of nurses and ancillary staff per bed, and they all need protective gear. Difficult to scale up this ICU bed capacity in the short run, even if the respirators are available. I'm a 35-year-old. Oh, yeah, sorry, that I just skipped into the next letter. So very, very good point by Eric.
So someone wrote to us the other day and said, "Don't call them respirators; they're ventilators." Is that correct? Is that right?
Yes.
Sure.
Daniel doesn't care.
I don't really care.
That's all true, right?
So it is all true, and it's a conversation we were having earlier today. I must talk a lot in addition to reading, was about right now, if you want to go in and adjust the settings on the ventilator, you want to turn up or down the oxygen, you want to adjust the rate or the volume, you've got to put all the stuff on and go in there. So maybe there's someone out there with a brilliant idea, but we were talking about some way, basically a remote control.
Yeah.
Right. So you're going to have to go in there because you need to look, is the person starting to have bronchospasm? There are reasons why you do need to examine patients every day or periodically. But just to change a vent setting, if there's a way to just use a remote control to decrease the amount of personal protective equipment and actually the amount of exposure events.
Yeah.
So how many times would you say are people going in and out of a room and throwing away the PPE afterwards?
Multiple. I mean, really every hour or two, somebody's in there for, people, they have a bowel movement. They, they have some sort of issue that requires either nursing care or a physician to reassess. And one patient you end up using a lot of personal protective equipment. Wow. Now, one of the things to address that we did at one of our drive-through sites is we had the people basically wearing these waterproof hazmat suits, and instead of going through as much gear, we would spray them down with basically a disinfectant. And so they'd step back, get sprayed down. It takes a certain amount of time, and then they would move on to the next one. But you're not actually going through these precious supplies.
That's very interesting. Kathy, could you take Emma?
Hi, love your show. Greatly needed in this time of chaos. I'm a 36-year-old triathlete who lives in Lower Manhattan. Since Manhattan is a ticking time bomb, over the weekend I relocated to the country to my family's pool house. The pool house is about 50 feet from the main house where elderly relatives live. However, my relative comes to a tool shed attached to the back of the pool house to clean the pool. So he avoids the patio. He stays a good 10 feet away from that patio. But if I exercise when they're not around, could my sweat droplets somehow linger in the air and infect him an hour or two later if he passes by?
I like this. And it's science is still science, right? The laws of physics did not suddenly change. I know people think they did. And the issue with, and this has been talked about a bit on TWiV, with things that float around in the air, so things that are potentially transmitted through airborne, these are particles that are smaller than about 5 microns. About 5 microns is a critical size at which something is small enough that it will float around on the currents of air, stay airborne for, actually in a normal room, we say about 30 minutes. In one of these negative pressure rooms with the air exchanges, only about 5 minutes. But if particles are above that 5 microns, so the particles that are created when you cough or you sneeze, these are just going to drop straight to the ground. And, and when you sweat, people probably notice the sweat is pretty big. Large. So it's big. Yeah. It's big. So unless you're one of those people that just glow and emanate these tiny particles of sweat, it's all good.
All right.
It's good.
The next one, Kristen wants to know, do we know the dose it takes to induce disease? How much virus?
We don't.
Nope.
Yeah.
Actually, Daniel, I had a question about that. Is there any evidence that if you are exposed to a larger dose, it puts you at risk for more severe disease? I wouldn't think so. But is there any sort of evidence about dose response?
I certainly have not seen any information on that. And it would be great to have an animal model. I guess I hate animal models where we're making the animals sick, but that's sort of a critical, and maybe that's something we get some sense by teasing out, amounts of exposure, etc.
Yeah, this came up because we were talking about the doctor in China who was in mid-30s who died.
Yes.
And so part of that discussion is, well, did he wouldn't be necessarily expected at age 30 to have such a difficult problem, though some people do. But could his heavy-duty exposure, because he's a doctor, have contributed to that? My knee-jerk reaction is, doesn't make sense to me, but I thought I'd ask you.
Yeah, there are certain diseases, I think, where the inoculum is key. We'll bring up cholera or something, and Dixon will jump in because he loves that. But but that wouldn't be unheard of. That the inoculum affects how sick people get.
Sure.
Okay.
So yeah,
we have a letter from a former student of mine who really liked now having taken virology.
Yeah.
She wants to know how anti-inflammatory drugs can treat symptoms of COVID-19.
As we've discussed earlier, current recommendations are Tylenol and
Then we have a slew of links.
Right, so I can run through these. A whole bunch of people wrote in to send links with resources and papers, and we greatly appreciate that. And I would love to read all these letters, but what we're going to do is run through the links with basically a couple of quick comments about each. And thank you for sending them. So starting off with Abby, who is has a background as a librarian and says she's hungry for data and requests links for information beyond the CDC and the WHO. Okay, Abby, buckle up. Ken sends a meta-link site. That's what I would call it. It reviews the various COVID-19 dashboard sites that people have put up.
That's good.
So you can look at that and then drill down to the dashboards that look good. William sends a whole bunch of useful links. A lot of these are papers and updates on statistics. So we'll go ahead and put all these are going to be in the show notes. You can get real-time analyses and GIS, geographically linked analyses and that kind of thing. Glenn sends in links to a couple of papers showing stats. These may be a little bit dated by the time people are listening, but you can look at the progress there. Rebecca sends a link to an interesting infographic about historical pandemics, deadliest pandemics in history.
Nice.
Ben sends a link to an article that asserts that there's a 90% rate of asymptomatic infection for this virus. Says it suggests that up to 90% of infections are asymptomatic, which has big implications for the number of people currently infected and disease modeling. I agree that would have big implications. I'm not sure that the data here demonstrate that that's the asymptomatic infection rate. But that is a big question, is how many people are walking around with this virus who don't even know. And I think as the testing ramps up, we may find out more. Eric.
Daniel, is that something we're going to learn, Daniel?
So it may take a while because the way to really figure out who got infected and then figure out how many were symptomatic would be to do serology. This is where you're doing basically a blood test to see evidence of prior infection, and then you can basically go through.
And I just tweeted an article that was in Science about one of these new serology tests that's been developed that could potentially be scaled up for that kind of thing, and a bunch of other people are also doing that. So yeah, that's the test that needs to be done eventually.
Alan, is that the ELISA test that was recently talked about?
Yes.
Yes.
Good.
Daniel, would you use an ELISA, an antibody-based test to diagnose someone, or is it we just use PCR for diagnosis?
So that's interesting, and it's always nice to have a PhD in immunology when you get asked a question like that, because it's complicated. But here's what we still don't know, but I'll lay out for people. When you get acutely exposed to something, the first type of antibody response you see is an IgM response, and about 3 weeks later, you see an IgG response. Those are sort of generalizations for different things. A lot of times, by the time someone becomes symptomatic, you're starting to see symptoms. It's because the immune system is ramping up. So a lot of times we make diagnoses by seeing an IgM being positive, and then later the IgG will become positive, but 2 weeks later. So right now we're not doing that. But there is a test, actually, it's we call it lateral flow. So it looks like a pregnancy test. You put blood, it flows out laterally. The first band is the IgM, the second band is IgG, and then there's a control band. And so there's a couple things that are great there. One is that is a very quick test.
Right.
So it may be able to, at first point, tell you about people that were infected in the past and are potentially immune.
Right.
And it'll be interesting to see when does the IgM band become positive relative to the PCR test, and also how specific, because IgM tests, IgM is a very polyreactive antibody, so they're notoriously non-specific. So it may have a high sensitivity, which is really what we want at this point. And so maybe it's a way of quickly figuring out who needs to be triaged for the PCR. So
Right.
I would be interested in seeing if we took stored serum that were taken for other things in January, December, November.
Yeah.
How many of those are going to be in the U.S., of course, right?
Yes.
yeah.
That would be
So Daniel, this lateral flow test is available for SARS-CoV-2?
So there is a Japanese company that actually makes this. It's not FDA approved, not available, commercially or approved in the United States, but the test exists, and I have, because it's not FDA approved in the US, I haven't been able to see much data as far as sensitivity, specificity, basically reliability of the assay.
Right.
But I'm pretty interested in it. I would love to have that information. But again, only if it's actually information.
Yes.
Reliable.
Right.
I don't know where you were, Alan.
Okay, so I'm right down to Eric now, who sends a report from Seattle and links to a paper about cryptic transmission, which kind of ties into the asymptomatic spread issue. And Eric says there appears...
And I will second that. I love that blog post or that modeling that is linked there.
Yeah.
Says there appears to be substantial low-level transmission in the counties around Seattle already, but the scale is not known due to very limited testing, which is pretty much the story of our lives these days. Everywhere except South Korea, which actually got on the stick fast enough.
This is Trevor Bedford. Yeah, he has done a very nice job with this. Yep.
Gregory sends in a link to a Scientific American article on bat coronaviruses, which is obviously quite timely, and says, I will not bore you with the details, but I will only say that your conversation with Dr. Barrick back on January 26th and his words about SARS-CoV-2 acquiring a community-based spread being a, quote, barometer for higher level of concern, end quote, are probably the only reason that I was able to figure out when to leave Rome, Italy, so that I could get home well before the country sadly saw the outbreak swell and the whole of Italy go into lockdown. And Gregory, I would say, welcome home. I hope that was an improvement.
I like that he says, I have donated the money I would have spent during a hoarding mania bulk buy of toilet paper to your Patreon.
Yes.
Oh, that's
excellent.
Yeah, no, that's fantastic.
Much more constructive use. And Jerry sends a link to an interesting fluid dynamics commentary suggesting recommendations for separation for social distancing. Maybe we should be saying 2 meters or more instead of 1 meter apart, just based on particle sizes, which is an interesting thought if practical. And Michael sends a link to an effort to manufacture monoclonal antibodies as a therapy, which we talked about one of those above, and here's another one. Yep. Curtis sends a link to a paper describing rapid vaccine candidate development. And again, we've talked about a few of these before. He says it's an interesting study currently undergoing peer review for a DNA-based vaccine that was developed in a few hours by scientists at Inovio Pharmaceuticals. And that's one of the cool things about these DNA and RNA-based vaccines. Of course, that's not now the rate-limiting step. The trick is you've got your vaccine candidate and you need a year or more to now get it into preclinical and then clinical trials.
And it needs to work.
And it needs to work, yes.
Yeah.
By the way,
forgot about that part.
So Justin sends links to papers on coronavirus haplotypes, and I feel like this is something we discussed, right?
Yeah, these circulating, variants that don't really mean anything phenotypically, yeah.
And says I was
nice quote there. Yeah.
Says I was supposed to be going to Japan and I was going to surprise Vincent with some cherry blossom festival pictures, but it doesn't look like that might happen right now. And for listeners who haven't been following the show for a while, Vincent is not a big fan of cherry blossoms. He just has an irrational fear
That's
of them.
just an angiosperm. That's all.
Yes. So Jason sends an article saying that influenza rates plummeted in Japan as the coronavirus measures were being implemented, which could be the natural seasonality of flu, but it could also be because people were finally following the advice we've been giving for years to wash your damn hands.
And wear face masks.
We haven't been recommending that.
And social distance.
Social distancing, that may have had an effect.
That's right.
That's the same kind of story we talked about, I don't know when, about the reduction in Hong Kong respiratory diseases at the same time.
Yeah,
right?
overall reduction in respiratory disease.
Yeah.
Which, that's good because it means that the social distancing is working, and that should be, tamping down the COVID-19 as well. And then finally, this is for all those folks who are sitting around their houses with bored kids, raising my hand. This is a link to a COVID-19 coloring book. This is mainly for younger kids, but it's a cool little coloring book that you can download for free and print out and hand it to your child. Or do it yourself. And that is the end of our storm of links for this episode, and thank you to all those folks for sending those in.
Thank you, Alan, for doing that.
I want to just add for Abby, who's a librarian, I'm sure Abby is skilled in doing searches. I know this in part because my mom's second career after being a chemist and a substitute teacher was being a librarian at corporate libraries, and she became really good at searching. And so if you want to search the primary scientific research literature, biomedical literature, use PubMed, P-U-B as in public, MED, one word. Right. And you may not be able to get the actual papers, but you can read the abstracts and you can get a pretty good idea of things. But if within the abstract and the link you see PMCID, you can click on that and you should be able to get the full text of the paper. The whole PubMed is supported by the U.S. government, and the PMCID is a relatively recent, within the last 15, 20 years, requirement for government-supported researchers to have their papers provided in a publicly accessible way. Sometimes they end up getting formatted by the journals, and you're reading it as it actually appears in the journal. But in PMCID, it's also still possible to get the text and the figures. Yeah.
And I will comment that the publishers have actually pretty much been doing the right thing under these circumstances and posting all this stuff online freely accessible.
Yeah, it's good. Hey, Brianne, can you take the next one?
Sure. I'm not sure how to pronounce this.
Neither am I.
Okay. Hyam writes, Hi, TWiV. I work upstairs from Barney Graham's coronavirus lab here at the Vaccine Research Center, NIH, that is developing the SARS-CoV vaccine going into phase 1 trials. As Vincent said, it is an mRNA vaccine being produced in collaboration with Moderna. It has, in fact, been through a preclinical study in mice that confirmed immunogenicity. In total, it will be about 60 days from the publication of the first viral genomes to the start of a phase 1 trial, slashing the previous record of 6 months for a DNA-based Zika vaccine. That's amazing.
Yeah,
it is.
As Vincent frequently notes in other contexts, the only reason they were able to do this so quickly is that they have spent the last 10 years studying other coronaviruses, especially MERS.
Nothing like basic science, right?
Exactly. So I think that there are lots of ways here where we're remembering that basic science is what is going to help us know about these things that we aren't expecting to come on our radar.
Yep.
Basic science is useless until it suddenly becomes the most important thing in the world. Yeah.
Exactly.
I read the paper that we linked last week about the development by the same groups of the preclinical studies on the RSV, respiratory syncytial virus vaccine, and I was consistently blown away as how much just really fundamental curiosity-driven basic science was drawn into play as they developed that thing. It's mind-boggling. Yeah. It's great.
So and 60 days is still mind-boggling as well.
Yeah,
it's good. Daniel, you think at any point you'll be involved in a vaccine trial? Or maybe an antiviral trial?
Certainly. And that's actually part of what I've been doing today. Is one of the nice little niches I have is I sort of step on both sides of the aisle, right? The basic science, the virology, the immunology, and then the other side, all the clinical work. So I'm hoping actually that as these therapeutics, as these vaccines come out, that I can coordinate with the people at Northwell, right? 20 hospitals, that I can, our organization's 3 million patients, I think, in the New York area, and basically get people access to these trials so that they can potentially be some of the first people who are immune.
Yeah, that's right. Rich, can you take the next and try and focus on the yellow stuff?
Yeah, sure.
If you will.
So, hi, TWiV team. I was a former medical lead for GlaxoSmithKline vaccines, and suggest non-clinical studies would absolutely have to be performed in advance of any phase 1 human testing. That's the sort of preclinical studies that we've talked about, cell culture and animal studies, and points out that we've cured every disease known to mice. It goes back to our old saw of mice lie and monkeys exaggerate. It's quite often that what he's saying is quite often that preclinical studies, although critical and valuable, don't necessarily pan out. An 18-month timeline to a potential candidate is extremely impressive. Based on my continued contacts in vaccinology, there are some brilliant minds working tirelessly to find a solution for the benefit of the community. Have faith.
And
James Tercy. Do you know James Tercy, Daniel, from Antares Pharma?
I don't, actually. No.
All right, Executive VP. So this is an interesting point because obviously there was some preclinical work for the Moderna vaccine done, but we don't know what it is because it hasn't been published and it's obviously proprietary. The only thing I can think of is they have a ACE2 transgenic mouse, which they could have put this in. They said they had some protection data. I have no idea what that means.
Yeah, I mean, I think I'm sure this has come up on TWiV, but there is a mouse model because you can't just give any mouse. You've got to basically have a mouse model that has the right modification to make them susceptible. Because coronaviruses, they don't just infect all mammals equally. They often infect more than one mammal. But ideally, if you're going to do the work in a mouse, you need it to be optimized to actually really function as a model. And this mouse actually was interesting. I was talking to some mice researchers about the fact that I think they were just about to kill the colony, right? And I think, because there, have been so many years. And then
it's in SARS, right?
And I think some were frozen, right, at Jackson Labs. I remember.
Ralph Barrick mentioned that last week.
Yeah. So
it was barracks that were almost going to be shipped for cryopreservation. That was Lisa Gerlinski. Talked about that.
What timing?
Yeah. So then Stanley Perlman's were already cryopreserved.
Yes, and it takes a while,
being
right?
Brought back out,
it takes a while.
Well, the thing is, when you cryopreserve, you have to check them before you sack your colony to make sure they're viable. Because sometimes it doesn't work, and you have to pull it out and recover it and do the implantation and everything. So it's not trivial.
Yeah.
And they're telling us here we may have to sack. They say, just cryopreserve them. Well, it's not
process.
It's not that simple.
Well, and you can cryopreserve sperm as well. So that's faster than having to do that.
And by the way, for non-scientific literate listeners who are tuning in here, we're not talking about freezing the mice, okay? This involves freezing eggs or embryos or sperm, as pointed out.
It doesn't work with people.
No, you can, and it doesn't work with mice either.
You free sperm?
If you drop a mouse in liquid nitrogen and then try and thaw it back out again, I guarantee you're not getting that mouse back. Yeah.
People do that, yeah. So the thing about the ACE2 transgenic mouse is you would have to do these experiments in a BSL-3.
Yeah.
You do.
Right?
You do.
So I don't know if Moderna had access to that, but someday we'll find out. Someday we'll find
by the way, a business downside of these rapid vaccine development platforms is for DNA and RNA vaccines, if you can do it fast in your company, it would be really easy for somebody who's not concerned about your patents to do it fast and knock off your product. So I think Moderna may be concerned about releasing too much of their proprietary information too early.
Right. Once the sequence is out there, a lot of people know how to do molecular biology.
I'm really very interested to see how this vaccine works out, because it looks like, from everything I've been able to read, it looks like really a cool idea.
Yes.
And I just hope it really pans out. It has, on paper, it has quite a number of very interesting advantages.
Yes.
Well, I have to say DNA vaccines seemed like a good idea.
Yeah.
But
Yes.
except for West Nile and horses, they really haven't
They haven't really
gone
panned out.
anywhere.
That's the catch.
Dixon, are you there?
Still here.
We have one from Dennis. Can you
Yes,
read the
yes. Dennis, an interesting letter from Dennis. Dennis writes, "My name is Dennis, and I live in Florida, Southern, and I'm 60 years of age. I was recently diagnosed with high blood pressure and also found out I have coronary heart disease. I quit smoking a year ago, but still booze it up each evening with scotch. Will I be better off getting this and surviving, or should I try not to get it and live to fight another day? I work in close contact with the general public." General. I don't know why it said it twice. "By the way, I have enough rice and beans to feed a small foreign country, and I know how to hunker down. Thanks for your concise expert knowledge on virus, and all. You guys are the best."
Avoid it.
You're high risk, dude. I would stay out of the way.
Yeah.
God.
I would avoid this at all costs.
And
Yeah.
the
they talk
dichotomy
about-
you presented
they
of
talk about-
getting this and surviving or trying to get it and live through it, that's not necessarily how this would play out.
No, I don't think so either.
They talk about this maybe starting to slow down when we get to about 70% of the population having been infected. You want to be in the 30%.
Yes.
Right.
Mm-hmm.
That's right. So move to China, basically.
We have one from Chris, who's out on Stony Brook, and he wants to know, how do RNA viruses persist in the environment? I know they have capsids in envelopes. And then the other question is, does mutation take place outside of the host? So that's easy enough to answer.
Yeah, that's a good.
No.
Even I knew the answer.
There's no mutation. Although, I mean, you could irradiate a particle with UV.
Yeah, you
it
could.
would cause thymine dimers or mutations.
Right. There wouldn't be
of various
mutations
sorts,
until the
right?
virus replicates.
Yes.
Yeah.
Right.
So viruses have to be replicating.
And even if that's the case, the vast majority of mutations happen during replication.
Yes.
And that's
Right.
not that's
so
not
just
a,
remember for the non-scientists.
yeah.
I was going to say, remember for the non-scientists, the virus is not replicating outside of cells.
Right. That was what I was going to point out.
And most of the places we get mutations are with replication.
Yeah, so not a silly question at all. If we're talking about bacteria, sure, they get mutations outside the host, but viruses, because they are obligate parasites, they only mutate inside the host.
So I think his other question is valid, though, in terms
Yeah.
of
Both
are.
if you're stuck in house for a month, everybody comes outside. He wants to know if the virus is still out there.
So it doesn't last forever. We talked about this last time on surfaces.
I'm sure you didn't listen.
Yeah, it's fine. I mean, some of these emails are older than, so
yeah.
it's fine. But, and as in teaching, it's always good to say things over and over
Yes.
again.
Absolutely.
Yes,
Yeah.
it is.
I've heard it's good to
When I
repeat
was
things too.
When I was a PhD student, my PhD advisor, Peter Palese, used to teach medical students at Mount Sinai. And he said, you can never repeat something too many times for medical students. It's always good to do that. I never forgot that.
And you can never explain the background simply too often either.
So the envelope viruses tend to last less time. And last time we talked about a study where they looked at the persistence of SARS-CoV-2 on surfaces, and it doesn't last forever. It lasts maybe a half a day or a day, depending on the surface. But I have to say, viruses without membranes, with just capsid, protein shells, they can last a long time. Noroviruses can last, right? They can. I have seen studies where they'll last up to a year.
Yeah.
Really?
Yeah, no, I don't like noroviruses. And, not only can they last a long time, but, in a cruise ship, the way their ventilation, they can actually get blown away, and we've actually seen airborne transmission of noroviruses in cruise ships. So
Yes.
when occasionally we'll have a patient in the hospital with norovirus, and I am just so careful.
Yeah.
Yes.
Um,
So Daniel, my wife had intestinal surgery in December.
okay.
Had a piece of her colon taken out for diverticuli, right? So the night she was there after surgery, they put an old lady in the room who had norovirus diarrhea.
Oh.
And my wife was well aware of airborne transmission. So she said to the nurse, "Can you please don't do that?" And she said, "Oh, it's okay. We wash our hands."
Okay. So the problem that I worry with norovirus is people with norovirus, the way I recognize it, and usually pretty good, is they come in vomiting. And it's and when you vomit, you actually can aerosolize.
Yes.
So,
yes.
Vomit. So there you are, you're in the room, and the person is vomiting. For the next 30 minutes, norovirus is floating around. Not cool.
That happens on airplanes often. People throw up, and then many people, including attendants, get infected because of the aerosol.
I was just thinking about this the other day. Remember, years ago, we had the video of the model that vomited.
Yes.
Vomiting Larry.
The mannequin. Yeah. What is the name?
I think Vomiting Larry.
I was disappointed they didn't name it Ralph. But
Impressive.
Yeah, it should have been Ralph for sure.
Yeah, that would have been good.
That's right.
Daniel, I had a question for Daniel. Is vomiting at all associated with this new coronavirus? I can't remember if you said that.
We don't see it often. Early on, people said, it doesn't really present with gastrointestinal GI, so it doesn't really present with diarrhea. But we're actually seeing the diarrhea. The big vomiting we saw was when people tried to treat folks with Kaletra. And as mentioned, what a disaster, right? 20% of these people were vomiting, which, as we're now saying, aerosolizes this, which, oh my gosh, what a disaster. And of course, this is occurring in hospitalized patients. So.
And so to Chris's question, that it varies a lot for different RNA viruses. For this one, we think it dies pretty quickly in the environment.
Yes. So I actually shared that paper that we talked about last week about persistence on surfaces with quite a few people. And almost all of them came back to me with the same question, which was a question I'd never really thought about, which was, but how long does the virus last on clothes?
Yeah, they didn't look at that.
They did not. And I was sort of baffled with that question.
Especially if people are sneezing into their elbows.
Yes.
Sure.
Yes. Daniel, you told me when you came in, you go home and wash all your clothes at night, right?
Yeah, I've been recommending this based upon some experiences in Italy, and having the idea is when you leave the workplace and you go home, particularly if you think about your feet, right, where people might cough, might be things on your shoes, and we now know there's a persistence. Having healthcare workers come in through the garage or a back door, you take your shoes off. This is crazy. Wash your clothes every day, right? I mean, a lot of doctors have a white coat and they just hang it up and they wear it for the week. Every time you change your underwear, change your white coat, maybe change your white coat more often. Come home. You throw everything in a hamper or in the wash. You shower off, new change of clothes, and that's great. And then, crazy enough, the next day when you go to work, wear clean clothes.
Yes.
Yeah.
No, it's a good idea. My wife even is telling me, since I'm out a bit, she says, don't wear the same clothes twice.
Yeah.
And I said, well, I only have a few shirts, so I...
I told Justin Aaron, I was talking to him about this, the doctor here, and I was like, Justin, if they're not paying enough, I'm going to buy you some extra white coats.
Alan, can you summarize the...
sure. Oh, gosh, I forgot to include the link for this. You saw this Facebook post as well?
I did. I didn't include it, but...
Right.
Oh, man. It's amazing. I mean, she is wondering if this post meant anything, right?
Right. So she wanted to know. Actually, the link she sent me over Twitter was something else entirely, and I didn't end up getting to the Facebook post.
So she emailed it to TWiV, and it's a Facebook post where that's basically about 2 pages of just pure nonsense about the virus and mutation and comparing it to flu. It's not even worth mentioning. The point is that people are just spewing nonsense out there.
Correct.
On social media, and then people don't know what to make of it.
That's right.
And there
was also a rumor that the Russians are trying to poison the well, so to speak.
That's entirely possible. And I really wish that Facebook, which is currently the world's largest media corporation, even though they produce no content of their own, would step up to the plate and take their responsibility as a media distributor seriously, which would include fact-checking. And I can point them to where they can find many, many, many unemployed fact checkers from the print news media who have been put out of business by things like Facebook. And you could have actual human beings doing fact checks and and stopping stuff that's starting to go viral and is full of nonsense. But that doesn't match the business model, because as long as the nonsense is circulating and you're scrolling through it, you are still an eyeball on the ads.
So they did kick off a $1 million grant program to help the International Fact-Checking Network to boost its capacity during this crisis.
Which is some help.
And also $1 million toward local newsrooms.
Which, $1 million for Facebook is like me pulling a nickel out of my pocket and tossing it in somebody's hat. But yeah, at least they're trying to do something.
It's better than zero.
It's better than zero.
The next one is all about face masks and surgical masks and N95s. And they mentioned that, as Daniel has said, people who work in hospitals have to wear them. So why wouldn't me wearing a face mask at least reduce, not eliminate the infection? And we've talked about this. If you wear it properly, it would work. But right now we don't have enough to give to the general population, right?
Right. Yeah, it's a tool. And if it's used incorrectly, it doesn't work.
Yeah. And she wants to know if there's little attention paid to eye protection. Is that something?
So historically, in a lot of healthcare settings, there was limited attention. And part of droplet protection, part of you being protected when someone coughs or sneezes, is protecting your eyes as well. And actually going into this, I was pretty heavy on re-education at one of the hospitals about if someone's on droplet, you got to protect your eyes, because influenza, you get that in your eyes, you can get infected. SARS-CoV-2, you get that in your eyes, you can end up with COVID-19. So eye protection is important as well.
Yeah.
So that was from Sylvia, who's a paramedic in Seattle area, not freaked out, just fascinated and wants to learn more. Good. You shouldn't be freaked out.
Stay calm and carry on.
Next person wants to know, how do asymptomatic people spread the virus even if they're not yet coughing or producing mucus?
Yeah, so it's the contact issue, right? A lot of times the common cold, you may not, rhinitis, you may not be coughing or sneezing, but your nose is running, you back of your left hand, people wipe their nose, they touch something.
Sure.
Yeah.
I remember there was a paper that was discussed on TWiV a while ago where the amount of virus that was coming out when people were breathing was measured. If I remember correctly, there was something about sticking one's head in a traffic cone or something like that.
Yeah, they actually measured
the BFU and your achu.
Yes.
That's right.
And it showed a lot of virus being transmitted by breathing. And so that would be my first thought here. But Daniel's idea makes a lot more sense.
Yeah, contact is a big part of it, yeah. That's why we're telling you to wash your hands. The next one is, should governments give consideration to state-provided childcare to provide care for health workers' children so the workforce can be maintained as much as possible?
Yes.
Yeah.
And for everyone else, too.
I think this rescue should be bottom up, not top down,
Hear, hear.
Yeah.
But I don't think it's going to be.
No, of course not.
Along those lines, but just more on a volunteer basis, a graduate student in our department organized a place for students or postdocs or anybody to sign up if they could help out with the healthcare workers in the hospital here and run errands for them or do pet care or other things like that. And so that was widely appreciated.
Yeah.
Cool.
That's a really good idea.
I've had some discussions with my buddy Niles about how if our government actually winds up giving everybody money to help bail them out in a non-need, based fashion, I'm going to find some appropriate place to donate.
Yes.
I'm going to, let's speaking of ground up, those who can afford to can help redistribute the wealth to places where it's needed.
Right.
Carrie wants to know why don't we protect at-risk populations as opposed to everyone, which is what we're doing now. Significant economic downturns kill people too.
question.
So wouldn't part of that be because so many people are spreading asymptomatically?
Yeah.
And so the only way we can really protect those at-risk populations is to try to keep the asymptomatic spread from happening?
Yeah, absolutely.
I would think
If
so.
you think about the opportunities for passing a virus around asymptomatically in a school or a restaurant or a bar or any other crowded place, that's where a major fraction of the spread is going to happen.
Yeah.
Tornellis says, well, we have a problem testing. Could we pool samples and perform RT-PCR on pools to sort out the negative patients?
I guess that's hard. If you took 100 people and you pulled them and said, someone in there is positive. Yeah, it'd be kind of hard.
Well, if you ran it as a matrix and did 20 tests on a 10 by 10 grid, you might be able to narrow it down faster. The problem I could foresee with this is that that requires a level of laboratory sophistication and organization and avoidance of error that would be very difficult to maintain in a clinical lab setting and would certainly not be permissible under current law, as far as I know. For good reason. So I think just the room for screwing that up is too large. And the RT-qPCR test should be something that, and is something that can be scaled up for manufacture very, very rapidly. Again, this is something that was demonstrated by South Korea, which should be shining a bright light of shame on the entire world at this point, because they got their act together and tested 250,000 people in short order. But here in the richest country in the world, apparently we couldn't do that. So this is yes, we currently have a shortage of tests, but I'm not sure that doing pooled samples would really be the solution.
Cornelius also wants to know where the furin cleavage site came from. Was it acquired while oscillating between humans and livestock or other animals? It's possible.
Yeah.
Probably acquired, moving through, probably went through some humans or animals or back and forth early on till it acquired that. Yeah, computer rebooting. Okay.
So I forget our previous discussions on this. Can we identify places where the a furin cleavage site is found in coronavirus?
Yeah, there are other coronas with it. Yeah, so it's just a matter of, it probably picked it up by recombination in some host somewhere, but we don't know where that happened, right? So we
right. I think the data seemed to indicate that it was close to a pangolin virus, but still, I think it was like 80-something%, not the 90% you might expect from the actual spillover host.
Right. Brianne, can you kind of take Chris's and do the highlights there?
Sure. So Chris mentions that on some of our episodes, we've been discussing several China-related items, and that we have sometimes speculated poorly about Chinese monitoring, who goes to wet markets, translation data, and statistics. And Chris notes that he cringed every time you and the panel regurgitated another xenophobic theory, and suggests that perhaps we should invite a Chinese graduate student or professor, because it would strengthen the podcast. And I think that Chris makes some really great points here. Thank you, Chris. And I think it's unfortunate if we have been saying things that are incorrect or xenophobic, and I think we should really commend some of the early science and early outbreak work that was being done in China that has helped us know as much as we do now.
Yeah, and I think we did point out how much better the Chinese response was to this than it was to SARS, and I don't know what xenophobic stuff Chris is referring to, but if you can point out something in particular, that's certainly not my intent, and I don't think that was anybody's intent.
No, definitely not. Not at all. And I can certainly see how having other perspectives would really help us out.
Absolutely.
And we've also had on some previous shows some emails from people from China or who have connections, family in China, et cetera, that have given us some additional perspective and would welcome more. From people who can give us insights, boots on the ground in China and other countries as well.
Yeah, I think all sorts of insights would be really helpful.
So we have an email from Janet, who is an ID physician, wants to know differentiating deaths from COVID-19 versus COVID plus bacterial superinfection. This is usually quite easy to determine clinically, as the patient often takes a turn for the worse clinically with new fevers, respiratory deterioration, radiological signs on X-ray. Also, I would always put this down quite clearly on the death certificate, i.e. cause of death would be respiratory failure secondary to bacterial pneumonia secondary to flu, for example. I've often thought that your podcast would even be more awesome if you had a clinician like an ID doc.
Great idea.
Wait, did I write that? Did I send that in?
Where do you think we could find one of those?
Given the mortality and morbidity is almost entirely born in the over 60s, maybe one strategy to slow down the epidemic would be to home isolate older people and let the infection run its course in the younger population. Preserves the majority of the workforce and means children can continue to go to school.
But it doesn't contain the epidemic. See above.
Trouble is that most of the teachers are not young.
Kids come home to older parents and grandparents.
Home to older parents and grandparents.
Et cetera.
Yeah. Kathy, you're there, right? You came back?
I am here.
Can you highlight commence? We're almost done, Daniel. I'm sorry. Sure. I know you're tired. 10 more minutes.
Do I look that tired?
Yeah.
Commensally writes, he notices that most of the coverage online and in the news, even from very scientific sources, has been tracking the progress of the pandemic by way of total cases per country. He asks whether there's a good way, or he or she, is there a good reason to keep looking at total cases in preference to cases per million?
No, there's not.
No.
Well, there you go.
I think cases per million is exactly how you should compare those numbers.
Yeah, that's a good point.
All right. Rich, can you summarize Andrew's?
Sure. Andrew says, I'm in Japan, and I note that they've had a lot of trouble performing enough PCR tests, which hints that there could be a lot more community transmission than reported. Yup. I also note that USA CDC seems to have had a variety of problems getting enough tests done. Yup. However, South Korea seems to be able to perform a lot of testing. Why? Why were they able to ramp up their ability so quickly? I actually don't have a specific answer to that. Do you guys?
I suspect competent leadership.
Well, back in January, they decided that they would respond and develop a test quickly. I don't know why the CDC had so many missteps, as we have heard before. But
I have some theories, but that would get into politics.
Yes. Right. I just don't know.
Well, hopefully we can learn from this.
Yeah.
Yeah, I guess they prioritized it earlier.
But I think South Korea, as I said, provides an example where if politicians are throwing up their hands and claiming, we couldn't have done anything about this, it was beyond our control. Nope. You sure could have done something about it, and here's how.
All right, let's do two more. Alan, can you summarize Joachim?
Sure. Joachim is basically wondering if every country should lock down like Italy. New listener from Sweden. My own country's health authority, for example, has so far only recommended people with cold-like symptoms to stay at home and banned all events with over 500 people attending. Sends along a blog post titled Coronavirus, Why You Must Act Now by Thomas Pueyo. In it, Pueyo argues that all countries affected by the epidemic must act as swiftly as possible by imposing the same kind of social distancing measures as Italy. What do you guys think about these claims?
So I think that I really like that blog post.
That's one that has gone crazy, right? He was the one. He came out a couple of weeks ago saying, "Look at the curves. You need to do something."
Yep.
So
and here we are.
Here we are.
Oh, and the Post has an update on March 19th. This article has received over 40 million views in the last week.
Yeah, it's very popular. Well, it's data-driven Post.
Yeah. And yes,
it's
every
reasonably
country
well done. Although it's a bit alarmist, but maybe at some point you need that.
Yeah.
Well, I think the discussion that we just had about the response in South Korea, they took all of these heavy-duty measures early on, and they were able to keep better control of the situation in South Korea than countries who have not responded as promptly elsewhere. So I think there are data out there that says that it has an effect.
For sure. We have one more from Germany, from Jonas. Jonas, Guten Abend. So he's from the Lower Rhine region of Germany, and he says he asked his company, which is 200 employees, a few weeks ago, what the contingency plans were. There weren't any.
Right.
So he gave a list of things that he thought he should suggest based on us to his upper management, like disinfectant in every workroom, hygiene training, flu shots, send people home with colds, paying the cleaning company extra hours. And are these appropriate? Well, I think by now you're probably not even working anymore.
Yeah.
Right. Did they close down businesses in Germany?
That's a good
I
question.
don't know for sure. I think so.
Well, these are all good things for sure.
They are good things.
If you're still working. But I would say also avoid groups of people more than 5 or 10 people. Don't have big meetings and so forth if you're still working and so forth. But you should be working from home. I don't know how long we're going to be doing that. What do you think, Daniel?
You know, it almost depends on how good a job we do. The better job we do, the longer this goes on. The worse a job, the shorter and quicker and worse it is.
Yeah.
And so I'm hoping it goes on for a while. I'm hoping we can, as everyone keeps saying, I mean, this concept of epidemiology is flatten that curve so we don't get above our resource capacity.
Yeah.
Right.
All right. We have more email. We'll get back to them another time. That is episode 593, microbe.tv/TWiV. I've started to post these on YouTube, just the audio, youtube.com/PROFVRR. And if you have questions or comments, we will get to them. Please send them to TWiV@microbe.tv. If you like what we do, consider supporting us financially, microbe.tv/contribute.
The money you would have spent on toilet paper.
Yes, indeed. One of the emails, which we didn't read this part, she said her mother is buying a bidet. That's a good idea.
Yeah.
Yes, yes.
Of course, over in Europe, they're like, what? We have them already, right? Great crew today on TWiV. Daniel Griffin, you can find him at parasiteswithoutborders.com. He's here at Columbia University Irving Medical Center. Thanks, Daniel.
Oh, a pleasure as always.
I think you like kind of having a break, right?
I felt like this was a little bit of a break, so thank you.
Are you going back to work tonight?
I'm going to just keep working, but I do have to take a little time off. I think, for any of the healthcare people listening, it's not a marathon. I mean, it isn't a sprint; it's a marathon. So pace yourself, and I'm going to hopefully set example. And tomorrow I am going to put my phone down and maybe spend a little bit more time with the family and a little less time with the virus.
Hear, hear.
Ori Lieberman was here. He's on Twitter, Ori Lieberman. Of course, he is a MD, PhD student here, hoping soon to get back to medical school, maybe in the fall. So thank you, Ori. Dixon Despommier is at parasiteswithoutborders.com, trichinella.org. Thank you, Dixon.
Things are looking good here from Fort Lee. Everybody stay well.
It's like the sun came out too, right?
It did.
Dixon, stay healthy, okay?
Going to try.
Don't make any unnecessary forays out into public unless we say you can, all right?
Well, we're pretty stocked up for about a week right now, so we're okay.
We enjoy your advice, and we'd like it to be here for many years more.
Thank you. I feel the same way.
Brianne Barker's at Drew University, which is online only, like many other places. On Twitter, she is BioProf Barker. Thank you, Brianne.
Thank you. It was really great to be here. And it was, novel to spend part of my day on a different online platform instead of the one I've been using for teaching. But I've made it through 1 week of online teaching so far, and it seems to have gone pretty well.
All right.
Yep, same from here. That's right.
Kathy Spindler is at the University of Michigan in Ann Arbor, Michigan. Thank you, Kathy.
Thanks. This was a lot of fun. It was a good way to catch up on things and to be doing something different from what I have been doing for the last several days.
You've been dealing with ASV, right?
ASV, online teaching, and lab shutdown.
Does anyone know what ASM is doing?
They canceled the clinical virology meeting. That's all I know. That's sometime in early May. And they're
going forward.
Okay.
They're going forward with ASM Micro
ASM.
in June. It's like right after ASV.
Right.
Mm-hmm.
They're probably waiting until the last moment when they can cancel whatever requires the earliest cancellation whatever reservation.
Right.
Or
Absolutely.
And then they'll go ahead and do that.
Yeah, I have no insight, and I thought maybe they were going to go to an online version, which is what Apple is doing with its
I'm sure they're keeping an eye on it.
Yeah.
Yeah, FASB is doing that, and ASV would like to consider that. We don't, we're not a big operation like some of those other conferences and societies. So we may still be able to do something, but just stay tuned.
Well, it's too bad because when ASV is grounded, so is TWiV.
Yeah.
No TWiV travel. I mean, Kathy and you and I are going to Germany in October. I don't know. Maybe we'll go, maybe not. Who knows, right?
Yeah.
Rich Condit is an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough, always a good time, and I feel grateful and privileged to be part of this crew. Thanks, everybody.
Alan Dove is at turbidplaque.com on Twitter. He is Alan Dove. Thank you, Alan.
Thank you. It's always a pleasure, and I'm going to go back to providing childcare and running errands on behalf of a healthcare provider because I'm married to one.
Very good. Excellent. I'm Vincent Racaniello. You can find me at virology.blog. And I want to thank everyone for doing this. I think we have a lot more new listeners now, and people really appreciate it. So many thanks for your participation. I certainly could not do it on my own. I want to thank ASV and ASM for their support of TWiV and Ronald Jenkins for the music.
I want to remind people that all of the letters that we read will be on the website with all of the links and the letters in full, so you can check those out.
Yeah, full text, microbe.tv/TWiV. There'll be a link at the bottom of the show notes, and we normally would read everything, but we're just trying to get through as many as we can because people have good questions, so that's why we're doing this. But you all have great questions. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.